Well, good evening, everyone. I want to start by thanking you for your participation tonight. And these rather crazy times we're living in, it's often hard to keep focus on what will be really important to us in just a few weeks when our practices begin to open their doors and our patients begin to return looking for our guidance. We hope we've got some interesting information for you tonight. Let me start by introducing myself. My name is Jane Beeman. I am the director of the Professional Relations Group here at Euclid. I need to make sure that I tell you that the presentation of the night by our speaker is reflective of his opinions and his working knowledge of orthokeratology. It doesn't necessarily reflect the FDA definition or even Euclid's approvals. That's why we always look to an independent practitioner to give us the best of opportunities to utilize their knowledge and to help us all. Our speaker tonight is Dr. Kevin Chan. Kevin is the director of the center at the Treehouse Eyes in the Washington, D.C. area. You know, Treehouse, if you don't know them, was the first innovative practice that was exclusively providing myopia management for children. They are dependent on referrals, and Dr. Chan spends all of his day working with children and myopia concerns. Dr. Chan graduated with dual degrees, his OD and a Master of Vision Sciences from the New England College of Optometry, and then went on to do more study at Pacific University in Oregon, the Virginia Medical Center in New York and Boston, and the Dimmock Community Center in Boston, and Braverman Eye way down in South Florida. Dr. Chan lectures frequently and is well known. He's also been invited many times on TED Talks and is a contributing editor on myopia management in many of the leading journals. So again, I'd like you to welcome tonight Dr. Kevin Chan.
Hi, everyone. Thank you so much for joining this webinar. Like Jane said, it's been a crazy and unprecedented time for all of us. But like many of you, we have all been going through different stage of life and definitely some challenges we have to overcome in the next few months or so. But remember, we're all in this together. So hopefully by this webinar, we're able to learn something new and enhance our knowledge. So hopefully by the end of this crisis, we'll be able to bring all these knowledge and clinical experience back to our clinic and help our patient. So I would like to thank Euclid for having me for this webinar. It's been a great honor and pleasure working with them all year long. And tonight, I would like to share with you about proactive myopia management, specifically about orthokeratology fitting for astigmatic patient. I have no financial disclosure for this event. So the main objectives for this evening is to help us understand the clinical indication of orthokeratology lens for children. And later on, we'll talk about the general guidelines for patient selection. And we'll also try to delineate the notion of fitting patient with astigmatism versus fitting patient with corneal toricity, which is the important topic for tonight. And last but not least, we want to put everything together and hopefully we'll be able to help us understand how to incorporate toric ortho-K lenses as a tool, as a proactive myopia management for our patient with clinical profile, specifically different from our spherical lenses. So there's been some preconceived notions about astigmatism in children. And as many of you know, you have been seeing children day to day, and you have been seeing different cases. You know, some of them may have some suspicion for keratoconus or any other corneal pathology. But one thing that we simply overlook sometimes is the level of astigmatism that we found in children. And many clinicians found that there may not enough demand for fitting toric orthokeratology lenses for children, particularly for myopia management. But let's take a look at the data in more detail. And one of the national study done by preventblindness.org, they have found that approximately 15 to 28% of children aged 5 to 17 years old that has been diagnosed with some sort of astigmatism. In a different study published in the Journal of the Ophthalmology in 2004, the group have found that patients with the root astigmatism is almost 3 times more common than those with against the root astigmatism older than 5.5 years old. And the data have revealed that more and more young patients than we expected have some degree of astigmatism. And that alone, they do not just have astigmatism alone. They will actually have a lot more refractive problem, including myopia and other things. And all these things combined together will further reduce the clarity and also induce higher order aberration, as well as the visual performance in general. So the next question for us to ponder is Ortho-K lenses, particularly Toric Ortho-K, is it feasible for children? So before we go on, I would like to recognize that Ortho-K lenses is not just simply a contact lens modality. It should be considered as a specialty lens, particularly for the function of myopia management. Because if you look at contact lenses, many of the commercially available products in the market tend to be used mainly for vision correction. But Ortho-K lens is a little bit different, as I would talk a little bit more about the mechanism and how it actually help our young patient. And when you consider whether Ortho-K will be good for our young patient, usually toric lenses would be a good idea to consider, because it's actually going to be helpful when you have someone who have some experience with unsuccessful Ortho-K lens fitting, or experiences may not be optimal, and sometimes there could be something missing in the equation. And toric lenses will come into play and help you resolve a lot of issues that you may not have thought about. Second is toric Ortho-K lenses will actually help improve lens instability and also the discomfort that patient may experience earlier. And having this type of sophisticated lenses would help enhance the success of initial fitting for patients with more than just spherical cornea, and help us reduce the chair time and maximize the success. There have been a couple myths that we would like to debunk before we go on, because many clinicians and parents may have these type of misconception about fitting their kid with Ortho-K lenses. The first common one is patients being too young, or they may be too difficult to deal with in terms of fitting the lenses, and there's too time consuming in terms of the preparation and follow-up. And from a parent perspective, they may also think that there's just too much responsibility for them to handle on a day-to-day basis, especially during this difficult time, and they may not think about contact lens as their first priority. So it may kind of undermine the need of Ortho-K lenses. And last but not least, many clinicians and parents found that just because they're so-called cumbersome for them, that's why they don't really feel compliant to the treatment. As a result, it will lead to little success. When it comes to patient selection, we want to focus on what really works for a young patient. We have talked about some myths. Let's talk about what really works on a day-to-day basis. In our clinic in treehouse size, we typically see one demographic only, which is children. All right, we fit patients with different type of modality, including Ortho-K lenses, soft multifocal lenses, and also the atropine as a pharmaceutical agent. All these things as a whole, we call it the myopia management. And one thing to keep in mind is that this is a really important service for a young patient, because we're talking about how we can transform the vision for life. And first, we have to look at the age. As we talk about, age shouldn't be a big factor, even though it's something you have to consider when you start a patient with particularly Ortho-K lenses. Typically, we're starting patient with myopia and astigmatism with Ortho-K lens fitting as young as 6 years old, and sometimes it can even be younger. depends on patient's maturity. And the second thing to consider is the refractive error in reference to the ametropization stage. For instance, if a patient coming in to your door and they are 7 or 8 years old, and to your surprise, you found that patient have -3 diopter with some moderate amount of astigmatism. Is this something that you found it normal or something out of your comfort zone? And many of you probably have, the first thought would be, okay, just prescribe single vision glasses or contact lenses. But have you ever thought about having the experience of Ortho-K lens for them? So when it comes to ametropization, you have to realize what is considered a norm for children. Using that example, if a 7-year-old coming in with -3 diopter myopia, it's definitely not something we consider normal. In fact, it had grown beyond the typical stage of ametropization. That's why this patient is probably at a higher risk of further progression over time. So you definitely have to take that into consideration. And family history definitely come into play. And study have found that having one or both parent being myopic, chances are their kids would definitely be more likely to become nearsighted and eventually having faster progression over time. And we talk about motivation and compliance briefly, is that even though the kid may be younger than you expected for trying Ortho-K lenses, chances are they will actually be more compliant and actually be more motivated than young teenager. Because I've dealt with a lot of young kids all the way to when they're going to college. Number of times I found that young kids actually are more likely to be compliant and receptive to your recommendation. And last but not least, we have to consider whether the kid is engaging in any athletic lifestyle or they're just sitting indoor most of the time doing computer work. And having someone doing taekwondo or reckless swimming, those are the good candidate for you to consider with Ortho-K lenses. So to begin with Ortho-K fitting, it is very important for us as a clinician to understand and also be familiar with how the lens actually work on the cornea. And when you look at these two pictures, what are the first impressions that come into mind? Well, for me, I put this up because I found that the picture shown on the left give me a sense of peace and serenity, just like when you go to do yoga or having a spa, you're actually sensing the Zen atmosphere. You feel peaceful. And why do I put this up? It's because when I think of fitting Ortho-K lenses, particularly for a cornea with a regular curvature or toricity, and it's like fitting something very, very flat and very uniform. And there's little chance that it will go wrong, even though there may be a chance that you may have to do some troubleshooting, which I'll talk about in a later slide. But the point here is that typically the lens generally have good support on a relatively smooth and even and corneal surface. So it actually helps develop the equilibrium fairly easily. In contrast, look at the picture on the right. You can see that, can you imagine, try to fit all these pieces of stone and rocks together and make it balance? It is probably, requiring a lot of balance and dexterity. And even a pro may not be able to do it easily. So the analogy here is that if we try to fit a regular Ortho-K lens design or somewhat the default design provided by the manufacturer on something that is like uneven or non-uniform cornea, it doesn't really match the corneal morphological profile. As a result, it will result in more rocking move and less stability. So it is important to keep in mind what kind of surface we're dealing with before we start any Ortho-K lens design. These are the two common nomenclature that we all encounter on a day-to-day basis in clinic. And they usually go in hand, but they're actually not synonymous. And let me explain to you why. So by definition, astigmatism is referred to the optical refractive error that results from corneal or in combination with lenticular irregularities. It can be used as a guide, but it shouldn't be used as a surrogate for toricity. And correcting astigmatism alone may not always address the toricity. And it is very important to understand that toricity, on the other hand, is considered a morphological attribution of corneal elevation at major meridians. And if you fit the patient with toric lens well enough, you actually help improve the physical fit and also help maintain the hydraulic equilibrium. So when it comes to fitting Ortho-K lens, particularly the one that I have been using extensively, the product by Euclid, it's actually pretty easy, straightforward with a step 1, 2, 3. And the key parameters I typically use for fitting Ortho-K lens for patient is that we want to consider the keratometry reading, the refractive error, and also the HVID. And but one thing I would include in my day-to-day basis is the measurement of corneal topography. Now, I know not all of the clinicians here are using corneal topography or any others equipment to do Ortho-K. Most of the time, they may just fit the patient empirically, which is fine. But I found that if there's a better way to help the patient with a little bit more sophisticated technology, I would consider corneal topography as a good starting point. So now here I would highlight the difference between measuring the cornea by the regular autorefractor versus the corneal topography. And typically the autorefractor just measures the central 3mm zone, and it doesn't really capture everything that we want to see, even though it may give you some basic data about the refractive error or how the K reading looks like, but it doesn't really describe what the actual contour of the cornea. On the other hand, if you have the corneal topography, regardless of what kind of brand you're having, if if you do have it, you will definitely have a better chance to capture the corneal image in a more extensive scale, meaning patient would have a better coverage, at least 10mm wide. And that tied to the previous slide about why it is so important to talk about topography, or at least consider the need of topography for your clinic. So it generally uses a compass or roadmap to help you guide in the direction of the treatment outcome, and also allow more precise measurement than just the refractive error or the K value alone. And specifically, it helps us understand the corneal contour, the astigmatic profile, the pupil size, corneal size, and eccentricity. Now, for the first two, we pretty much understand why the contour and astigmatic profile are important. But for the latter three, it may not be intuitive for some clinician, just because some people found that it's more research-based and it isn't really applicable to our clinic. But more and more time, I found that pupil size and eccentricity does play a role when it comes to the nuances of how to fine-tune the lens fitting. And specifically, I would talk about the eccentricity here. So by definition, eccentricity is described as the rate of corneal flattening from the center to the periphery. So in other words, it's just to tell you how much the cornea differ from the perfect sphere. And generally speaking, for corneas having lower E value, it indicates more sphericity. On the other hand, for corneas having higher E value, it tends to tell you that the cornea tend to be more elliptical. So here's a paper published in 2013, and the group was looking into the corneal shape and eccentricity in the population, particularly in Eastern Europe. And I think the study was done in Czech Republic, and they recruit approximately 1,400 subjects, and they found that the mean and median E value was approximately 0.41. So it kind of gives everyone some guideline about what to look for when it comes to the E value. And typically, the Euclid product would be able to fit well for someone having e-value ranging from 0.3 to 0.6 in general term. But there's obviously some other outliner we have to consider. So here I would like to show you the classic example of what the apical cylinder or astigmatism look like. And it is really essential for us to identify the type of corneal contour looks like before we go on to the actual design. And personally, I found that the term cylinder seems to be more applicable compared to the word astigmatism when it comes to describing corneal shape or morphology. Specifically, what we're looking at here is the apical cylinder. It generally is confined within the central 4 to 6 millimeter zone and within the pupil. And it can be vary in size and shapes, but most likely they will be localized within or actually coincide with the pupil. On the other hand, you also may encounter some of the irregular corneal cylinder. It's called a lumbo to lumbo cylinder. So generally speaking, this type of cylinder is more extensive in size and also more variable in shape. And it comes with mostly with the rule cylinder, but it can also be against the rule or oblique. And generally go beyond the central 4 to 6 millimeter zone size. But one interesting thing is that it can be quite difficult to capture what we're seeing here. What we're showing you here is just a classic textbook example, but most of the time it may not always be happening, in real life. The reason why I said it's difficult is because many kids are having some kind of narrow or tight lid apposition. When they open the eye naturally, it doesn't really fully reflect the entire 10 to 12 millimeter zone. So as a result, it could be very difficult to appreciate, the top, especially the one that has been covered in the top eyelid. So whenever those eyelids are tight or narrow, sometimes you have to do some manual maneuver. And it's by gently pressing against the top eyelid against the, not the globe itself, but the superior orbital arch. That will actually help, help avoid any types of induced astigmatism. Because when you press against the globe, it generally induces more red zone shown on the topography. So which is not needed and also not prefer to do so. So here's a schematic diagram I'm going to show you about the basic anatomy of what the emerald toric lens looks like. So here there are several different features. We'll start from the middle to the periphery. Starting from the middle, we have the back optic zone radius, followed by the adjacent reverse curve, and then followed by the alignment curve. And last but not least is the skirt called the peripheral curve. And it's quite similar to what we encounter with the regular spherical Ortho-K lenses, but the reverse and alignment curve is designed for particularly for the toric component here. And here I would like to show you what the fluorescein pattern actually corresponds to the schematic diagram here. Here you can see that in the middle, you can appreciate the central flattening effect and correspond to the bearing by the fluorescein. On the reverse curve, it shows the mid-profile steepening that corresponds to the fluorescein pulling. And adjacent to that, you'll see the alignment curve, which is called the landing zone. It actually helps enhance the overall central stability. And the edge lip is also important, even though it may not be the first thing you want to consider, but having enough edge lip will actually help enhance the tear exchange and increase better comfort. Here's a general fitting guideline about all types of Ortho-K lenses, including both spherical, but later on we'll talk about specifically toric lenses. So here's a couple things you want to take home is that whenever you have a young patient with refractive error less or equal to -5 diopter, refractive astigmatism less or equal to 1.5 diopter with the rule, or maybe a 3/4 against the rule. all right, those patients would be qualified for fitting Ortho-K lenses. And in terms of the K reading, and generally it ranges from 40 to 46 diopters, and HVID should also be greater than 11 millimeter. And generally speaking, for someone with larger HVID, it tends to have a greater sagittal depth compared to the smaller cornea when measured with the specific cord length. What I mean by that is, generally speaking, if you have a larger HVID, it would affect the actual lens diameter you want to choose for the patient. For instance, for two different patients having the same level of keratometry reading, about 42 diopter, if someone having a 12 millimeter HVID compared to someone with 10 millimeter HVID, for the one with 12 millimeter HVID, that patient tends to fit better with steeper base curve and or larger diameter lens compared to the one with a smaller HVID. As we move on to the fitting profile specifically for toric Ortho-K lenses, it's very important to understand the main goal of why we fit this patient with toric design. And the level or extent of corneal cylinder come into a really pivotal play here, because we want to understand the main goal of using this type of toric design is not just to correct the amount of astigmatism, but it's also to ensure lens centration as well as stability in order to optimize the overall treatment outcome for myopia management. And the method we typically adopt for dealing with this is by using the term called sagittal height differential. And later on, we'll explain and elaborate a little bit further. Let's go back to recap this picture. All right, we have seen it earlier. And again, this kind of balancing act requires a lot of, skill and dexterity. If you just simply pick a random rock, on the floor and, pick it, try to scale it like this, it's probably just going to take you a long time. Without proper strategy, probably it's just not going to be fruitful for you. So here we have some guidance about what we can do for sagittal height differential. By definition, sagittal height differential is defined by the difference between the steepest meridian and the flattest meridian on the cornea. And for the take-home messages here is that for someone having the differential less than 30 microns, we typically would fit the patient with the spherical lens design. For someone having the differential greater than 30 microns, we typically would fit the patient with toric lens. And the three bullet points shows the subcategory of what kind of differential that correspond to different type of toricity. And one thing to know is that for someone who have low amount of astigmatism, does it mean they always qualify for spherical lenses? Chances are, maybe, but according to a study by Randy Kojima in 2016, actually more and more patients having low amount of astigmatism tend to have certain level of differential greater than 30 microns. For that case, you definitely want to try to expand your realm to consider toric lens design for patient. And one thing I found that just learning from my own failure is that we typically want to start with the lower toricity level in order to avoid tight fitting. That way you won't overshoot the lens, and then it's actually easier for me to work the patient one step at a time instead of walking back downward. So starting with a lower toricity would be helpful. So this slide may look a little bit convoluted or busy, but I just want to point out how I typically address the differential analysis for someone who may have some questionable amount of toricity. So first thing is to measure the steep meridian, and you can click the button, showing you steep, and then it will generate the weight average at the steep meridian. that tells you the actual micron on that meridian. Step 3 is to measure the flat meridian, and they will generate the actual micron on that meridian. So by taking all these measurements, you're able to generate the actual overall differential. The next slide will actually show you specifically what a real example looks like. So here we have two examples. The one shown on the left is considered the apical cylinder, just in first glance. The one shown on the right is the limbo to limbo cylinder. So the difference here is that you can see we have already done some measurement on each meridian. So let's look at the calculation here. The one shown on the left, horizontal meridian, shows to be having 1470 micron. Vertical meridian, 1490 micron. The overall differential here is around 20 micron. So for that matter, I put a patient, with a spherical lens design. In this example, we're seeing that the horizontal meridian is 1444 micron, vertical meridian is about 1489 micron, and then the overall differential is approximately 45 micron. And because it's greater than 30 micron, I typically would put patient into a toric lens design. But again, it's just a general guideline. It may not always apply to all different cases. So another big thing you want to consider is the extent of corneal cylinder. We talk about how to do it, mathematically, but at the end, you want to, look at the overall extent of the cylinder to see how to fit the patient with the lens properly. So having the lens with good cylinder is key because it actually would govern the lens stability. In a study done in 2017, they actually can predict how the lens perform in response to the corneal elevation. And specifically, the result shows that there's a direct correlation between paracentral asymmetry of corneal elevation and the overall direction and the magnitude of lens decentration. And what they found specifically was whenever you have a patient with a tendency of inferior temporal decentration towards the temporal corner, it tends to have more decentration there. So it really tells you that by looking at the lens, how they perform upon the first fit, you're able to kind of predict or have an assumption of how the lens will actually perform in the long run. And one thing I want to just highlight is briefly is the ethnic variation. And even though not many clinicians pay attention to this kind of factor, but I found that interestingly enough, many patients who are Asian or Hispanic in descent, they tend to have more limbo limbo to limbo or oblique cylinder shown on the cornea. And we still don't understand why it happened that way, or maybe just the genetic factor that come into play. Another thing to keep in mind is that not all toricity would actually develop equally or symmetrically. So for someone having asymmetric toricity, you have to be careful about what to fit with them. Because this slide tells you that this is the least you want to see on a patient's corneal topography. And what we're seeing is that the scale shown on the left is the 90 degree. The one shown on the left is the 270 degree. What we're seeing here is that at the meridian of 270 degree, patients have a really remarkable corneal steepening, kind of analogous to someone with either pellucid marginal degeneration, or someone if the steepening effect is focusing on the inferior portion of the cornea, you have to suspect of keratoconus. And when it comes to who would be not a good candidate, is that you have to watch out whether you can correct the patient down to 20/40 or better, or whether the refractive astigmatism corresponds to the actual corneal toricity. If they don't really match up, or you see a large discrepancy, that will be a red flag for you not to fit the patient with Ortho-K lenses. And last but not least, you have to watch out for any asymmetry or skew pattern on the corneal profile. Here, I would like to show you a real example that I saw a couple months ago. Patient is 10-year-old of Asian Indian descent. Her refractive error is about 450, myopia, and minus 150 refractive astigmatism. And at that time, after all these calculations that I showed you earlier, I fit the patient with the toric lens design, the Emerald Toric, with the 1 diopter astigmatism. And here, I'm going to show you the corresponding fluorescein pattern. Here you can see when patient first fit with this type of lenses, you may not, you may wonder what happened, whether the lens will be decenter significantly or not. But, when you follow this guideline and, do the calculation properly, you can actually see the lens are fitting perfectly on your eye, and you expect some movement upon blinking. Now, let me play you one more time here. Just to recap some of the nuances, you can see patient have a really uniform central flattening correspond to the steepening effect mid-peripherally. And then this patient also have a really ample peripheral skirt right there. So this fit is perfect to me upon the first trial. So when it comes to troubleshooting, we all know that sometimes life doesn't go, as smooth as we expected. So we always want to expect what to do when it comes, to different type of discrepancy there. So here I would like to introduce you one of the most common troubleshooting I encounter on a day-to-day basis. This is called a lateral decentration. As the name implies, the lens would typically move sideways from side to side, nasally to temporally, and this could be quite bothersome for some patient. And now let me explain to you why it matters first of all. And when you look at lateral decentration, sometimes we have to look at the lens diameter. Most of the time, it happens when there's not enough lens diameter. The lens is not big enough, and it generally reflect that we may have underestimated HVID. And also, sometimes when patient did not open the eye wide enough, when you do the corneal topography at baseline, it will actually undermine the overall toricity. So there's something called watermelon seed effect. I don't know if anyone heard about this term, but I found it very interesting when you look at the lateral decentration. Some patients, especially for those who are Asian or Indian descent, I found it, I don't know if it's a coincidental thing, but it just happened most of the time, in those demographics. And patients do have the lens, when it first put the lenses on, the lens would sit properly for about 10 seconds. But after the first 10 seconds, would tentatively move mostly nasally towards the nasal corner, as if the eyelid itself, when they blink, it squeezes the lens as if it's like watermelon seed. It squeezes it towards one side, mostly nasally. And that will actually causing a lot more discomfort than patient would want to anticipate. And so this is something you have to watch out, especially when you deal with patients with different demographics. But one thing you want to do for this particular issue is to increase the lens diameter. Most of the time, I would target the HVID size, approximately 95% of the HVID, in order to get the optimal fitting. Second is the issue of central island or central vaulting. It is also pretty common upon the first few weeks or so. The reason it happened is because when there is excessive sagittal height, and the lens is basically floating around, and the initial fit wasn't really proper. And patient, would complain about vision starting to do well for the first couple hours when they wake up, but they start to deteriorate upon the mid-afternoon, and it just go downward. But one thing to keep in mind is that sometimes not every issue needs to be addressed right away. Whenever you see a problem, you may want to take a step back and think about, what kind of issue we're dealing with. Sometimes central island can actually dissipate itself upon the first couple of weeks or so. So observation could be one of the solutions for this type of case. But if it isn't resolved after a couple of weeks, I will typically start with flattening the base curve. Sorry, not the base curve. Flattening the reverse curve, which is the mid-periphery zone. And that way you can actually help bring the lens down a little bit to facilitate negative hydraulic push on the central epithelium. That will actually help resolve the problem most of the time. When it comes to vertical decentration, this is for me is a love-hate situation, because I found that this type of vertical decentration is really interesting to look at, but at the same time it's also one of the most challenging cases that I may not be able to resolve even upon a few trials. So let's look at the first type of vertical decentration, known as the smiley face configuration, and usually results from insufficient or asymmetric sagittal height. Basically indicate the flat fit. The lens are just being too flat on the cornea. And from a patient perspective, they typically would complain about lens keep sliding when they blink around, or even if they close their eyes, they're still gonna experience a lot of discomfort just because the lens are not sitting well. And usually what I would do is by steepening the alignment curve and try to bring the lens lower towards the center. And if it doesn't work, I have to consider combining other technique, is by increasing the level of toricity. Usually I go by 0.5 diopter interval in order to, like what I said earlier, we don't want to induce too much all at once. Otherwise, patient would definitely feel the tightness of the lenses. They may not be feeling comfortable at nighttime. Another type of decentration is the inferior part, known as the frowny face configuration. It similar to the smiley face one, it generally results from insufficient or symmetric sagittal height, but it generally indicate the lens are a little bit steep. And patient would complain about when they wake up in the morning, lens are suctioning their eye, they're feeling so tight, and even having a hard time to remove the lens in the morning. And it's actually one of the most stubborn conundrum that I still haven't mastered this type of troubleshooting yet. But what I found was if you were able to flatten the alignment curve, which is the one beyond the reverse curve, that will actually help bring the lens up a little bit back to the middle in order to give patient a better comfort and also optimize the overall treatment outcome. But again, I typically recommend clinician to consider walking step by step, baby step, and it will actually help the revision be more optimal. So here I would like to share you, a few case study. The first case is about 11-year-old Hispanic female, and mom says to me that my daughter has, vision has progressed by almost 2 levels since a year ago. What I understood was it could mean 2 diopter. In terms of family history, mom is fairly myopic, minus 450, but that is ametropic. And patient says she pretty much engaged in the screen all day long and almost every day, and rarely go outside doing any sports. And mom was wondering about specialty contact lens for nighttime wear, because she quotes someone from her neighbor that her son or daughter were wearing this type of lenses. So she was curious about what to do with this. So here's some clinical baseline data. Patient come in with the habitual glasses, right eye minus 2.25, left eye minus 150. K reading is ranging from 43 to 45, pretty average. And when I cycloplegic the patient come with the refractive error about 2.5 on the right, 2.25 on the left. Both 5 have relatively low amount of refractive astigmatism, be able to correct to 20/20. Now, one thing is that when I first start with the baseline consultation for myopia management, typically we'll also want to collect the axial length measurement. And for this particular patient shown to have a relatively long axial length, approximately 24.5 on the right, 24.4 on the left. I know some clinician may wonder, okay, what if I don't have the measurement for axial length? What should I do? Usually, it would not be the deal breaker at this moment, but like many other aspect of eye care, we want to keep enhancing the quality of care for patient. If you don't have axial length measurement, you're missing a big pie, in the cake. And patient would definitely want to know more about how myopia would correspond to the axial length changes. Later on, we'll have a couple of slides showing you how it applied to the actual outcome. So here's the baseline topography. I'll just recap the refractive error here. But one thing I want to show you is the actual K delta. K delta suggests the overall change of the corneal toricity. Here, as you can see, the K delta exceed the amount of refractive astigmatism in each eye. So it tells you something about, fitting patient with the spherical lens may not be the best idea. You have to kind of do a little bit more analysis. Here is the snapshot showing you the it's a capture showing you the Pentacam AXL that I do in a clinic. And what it tells you is the overall differential by using the calculation shown in the little box right here. You can see the big cross right here. For the interest of time, I will just highlight what I found here. For the right eye, this patient showed me 22 millimeter on the right, 36 millimeter on the left. And as a result, I start with the patient with a spherical lens on the right, and then toric Ortho-K lens on the left. Here's the serial topographical diagram from baseline, 4 weeks, 3 months, and 6 months. As you can see, the patient starting from day 1 to the first few weeks, vision may not always be perfect. And you can just reassure that patient would actually have to go through a brief phase of gradual adaptation. Vision may not be 20/20 right away. But upon the first 4 to 6 weeks, most of the time patient will respond to the lens accordingly. As you can see in this example, patient is seeing 20/20 upon the first 4 weeks, and it's been steadily stable. Here is the left eye showing you patient was fitted with the toric lens design with the 1 diopter level. And again, 4 weeks, 3 months, and 6 months, result is gradually getting better and better. And the lens are also fitting optimally. Here, what I like about Pentacam AXL is that it will able to capture the overall comparison from baseline up to whenever you see the patient back. For this patient, we see her back 6 months, and then a year later, the one shown on the right is telling you the overall differential map. And here, I'd like to highlight the axial length changes from baseline upon year 1. It actually changed by less than 0.1 millimeter in size, which is remarkably stable. And essentially the conclusion for this is that patient does not have any changes of myopia upon the first year. Same thing for the left eye, less than approximately 0.1 to 0.2 millimeter, which is still pretty remarkable. So lesson learned for this case is that we should try to look beyond refractive astigmatism alone, even though it is very important, but we shouldn't overlook this. Second is to try to fit Ortho-K lenses on the basis of corneal contour and toricity. And this highlight the take-home message of why we talk about Ortho-K so much, and particularly why we spend so much time on toric lens design. It's because we try to help optimize the centration and the overall treatment outcome for slowing down myopia. Here's another case, 7-year-old Caucasian male, first wore glasses at 2.5 years old. Interestingly, no family history of myopia. Patient was first referred to me by a pediatric ophthalmologist because the ophthalmologist found that the axial length have continued to lengthen by approximately 0.35 to 0.4 millimeter per year. So that is considered pretty excessive for an annual progression. Because when you look at the previous example, patients show me less than 0.1, but here patient have shown 0.35 to 0.4. And patient also have long-standing refractive amblyopia in both eyes. Patient has been treated with atropine 0.10% for about a year, but result has not been so promising. So parents were wondering and interested in trying whatever possible in order to slow down their son's myopia. Here's a snapshot about the baseline clinical measurement. I will just highlight a couple of things. When I cyclopictured the patient was actually slightly more hyperopic compared to the habitual refraction. And currently, right eye is about 5.75, left eye minus 450. As I said, patient has been diagnosed with refractive amblyopia, so the best corrected VA was about 20/50 on the right, 20/40 on the left. Axial length, slightly even longer. Consider he's so young, only 7 years old, but with a longer eye than the 11-year-old. So that's another red flag for us to consider this patient may be at high risk of further progression of myopia. Here's the baseline topography, showing you this is so uniquely different from the previous case. Patient have illustrated the limbo to limbo astigmatism. And as highlighted by the refractive changes and the K delta, you can see the overall comparison. The K delta on the right eye is pretty close to each other, whereas the K delta on the left eye is having a large discrepancy. So at that time, I try to pay more attention to how to optimize the fit on the left eye. So here is what I do with the sagittal height differential. Again, like the previous example, the cross would help me identify and do the calculation. So it draws to the conclusion that patient have a sagittal height differential approximately 45 millimeter. I'm sorry, the unit is was a typo. It should be 45 micron in both eyes. And but interestingly, when I talked to the consultant, we conclude that patient would actually be benefit with the 1 diopter toricity on the right eye and 150 toricity on the left eye. Just because of the overall corneal contour, it actually differ quite significantly. So we typically will start the one with a more atypical contour with a higher toricity. So what I want to highlight for this toric lens design on the right is that this is a tangential map showing you the overall curvature change. And at first glance, you may notice, okay, this is not a typical classic example of what a Ortho-K lens fit should look like. At first glance, I also kind of second guess myself, did I do anything wrong with this patient? But one thing I want to point out is that this is in a scale of a standard power from 35 to 65 diopter, and they actually range from a 2 diopter step level. So this is something that you have to watch out, check the scale on each topography. Sometimes it may not, the default may not actually work for your specific case. So here we're seeing you this, showing you the same eye, same patient, and what I changed was the actual range of scale from 65 down to 45 diopter, and it goes by 1 diopter step interval. So you can see again, I will flip these 2 slides back and forth. You can see the first slide with a larger scale and a slide with a narrower scale. It tells you that the scale does matter. This patient from baseline to 2 weeks, patient was improving from 20/50 to 20/30. From 2 weeks to 2 months, at 2-month level, patients continue to see 20/30 and is stable all the way to 4 months later. And again, I want to highlight the fact that by changing the scale here, it doesn't really alter the raw data. It only helps reflect the true data because we're seeing the changes, the corneal changes by micron. So if you set the scale too high or being too wide, you're actually underestimating a lot of data that is actually shown, with a narrower scale. So here's another example showing the left eye. At first glance, I kind of second guess myself, but once I do the scale changes from 65 down to 45, again, the map shows me to be pretty beautiful. Here is the overall differential map showing you from baseline to 4-month level. The axial length changes by about 0.16 millimeter in size. And the left eye, even better, less than 0.5 millimeter in size. So again, compared to the previous analysis or the result that is captured a few years ago from the clinic, it was shown that it's about 0.35 to 0.4. Here, we're actually cut the level of axial length changes by almost, tenfold. It's actually quite promising, and patients are really, ecstatic about the results. She can actually see better than before. So here, the take-home message for this case is that toric ortho-K lens can actually be used if used properly and effectively. It will actually be helpful for the goal of myopia management, as you can see in the axial length changes. Second is by using proper scale setup would actually help you with a better or more accurate interpretation of clinical outcome. And sometimes you also have to consider having combined treatment approach, including optical and pharmaceutical. Like in this case, patient was first treated with atropine, but it wasn't potent enough. That's why we decided to add ortho-K lenses as the adjunct treatment for this patient. So I know I'm running out of time, and I really appreciate your time attending to this webinar. And I know there's a couple questions that found in the Q&A section. So I will pass the time back to Jane or David.
Yeah, I started to say, Kevin, we got some great questions. And, I've been writing so many notes. I'm not even sure I can read everything because I picked up so much as you went along.
Yeah, I apologize for not taking the question
great.
right away because I have a hard time to focus, presenting and also answering the question. But if Jane can help me out,
it helps because I can bundle them together. So we've got Eric asked if he said he was very interested in knowing and looking for your guidance. Is it recommended that all patients have a cycloplegic refraction before you fit them with Ortho-K?
Yeah, that's a really good question. In my clinic, I typically cycloplegic all patients, without any exception, just because patient, as you know, we're dealing with a specific demographic. Kids tend to over-accommodate a lot, and you will not be surprised by having, a slightly more myopic shift by almost 1 diopter easily. So without cycloplegic refraction, you probably would underestimate a lot of refractive changes.
Mm-hmm. Now, John wanted to know, does anyone measure temporal keratometry with a keratometer? I remember there used to be some ways to do that, little dots and you move things around. Does anybody do that anymore?
For me, I'm not quite familiar with this equipment, so I cannot comment on that. At least not in my clinical education and not my experience either.
Yeah, I think that was before your time, Doctor. Let's see. Dr. Chang. Okay, so Pin Chang, let's see here. Please show us your perfect fit fluorescein picture again. And so then we can determine the ideal width of the edge lift. How thin of an edge lift is too thin if they have good fit and good comfort and no SPK? So, I think there's a lot of questions. We have a lot of people today who were not really given a lot of training in GP fitting, and they really don't know how much is a good edge lift, how much is too tight of an edge. Can you go back to your picture and show them how you make that determination?
The view that I showed you earlier.
Mm-hmm. Yeah.
So typically, this is, in my opinion, this is considered a pretty perfect fit with the amount of toricity that I put on this patient. As you can see, the mid-peripheral, start with the central part first. The central flattening effect tends to correspond to the central bearing, and you can see slightly larger than the pupil size. Let me replay it again. And what you want to find out is the overall ratio between the central flattening and the mid-peripheral steepening. You can see that the steepening effect on the mid-peripheral is not too wide. You don't want to have the band being too wide. Otherwise, it means that there's a lot of tear exchange and a lot of leakage. And sometimes you want to just aim between about 0.2 to 0.3 millimeter in terms of the band width. And when it comes to the peripheral edge lift, again, you can see that it's less than 0.2 millimeter in terms of the thickness. So again, this would be my personal clinical guideline, but it doesn't reflect the actual standard guideline because everyone may have a different ruler, a different set of parameters that you want to see.
Well, I think it's kind of common training. You know, I'd agree. This is a really good what's considered an axial edge lift. You've got that prismatic tear in there. When it moves, we could see tears moving under it. That helps. So it's not binding or biting into the cornea at any area. It's free, and the lens can move freely, and it can pump that tear behind us. And that's what we want that edge lift to do. If that edge lift was too high, it'd be bumping into the underside of the tarsal surfaces, and it would be uncomfortable. So edge lift is a very important factor. I think a lot of us don't think about as much as we should.
That's right. I
Great.
agree. Mhm.
Okay, now how can we differentiate irregular corneal astigmatism that may be very early keratoconus versus just an atypical corneal astigmatism?
Yeah, that's a really good question. Even though, we didn't spend too much time trying to identify keratoconus here, but this is not the emphasis of the talk. But like what I show you in one slide, what not to consider for Ortho-K is, first of all, you have to rule out patient with chances of keratoconus or any other corneal pathology. So the slide showing you is the asymmetric or skew pattern. When you go back to, I hope I can find it. Here we go. So this is something that you want to watch out for. If you have something atypical, asymmetrical, or skew pattern, you don't actually know what term you're gonna describe this, then it's probably not the right fit for Ortho-K. And in fact, this patient is very likely to be prone to further progression of keratoconus, because if this corneal steepening or thinning effect is happening in the inferior quadrant, you definitely want to check out with other providers, especially screening for keratoconus.
Yeah, I think that's the big take home is if you are suspicious, you have to make sure someone goes through the steps to screen them out. Because if it's keratoconus, we don't want to go trying to manipulate a cornea. I was always taught if you had a retinoscope, you could look for a scissory reflex. And I always look to see if the astigmatism is in an oblique axis, because if I see that, it makes me really suspicious, because keratoconus generally, not always, will fall at the oblique axis points. Are those two things you've heard too, Kevin, or were trained?
Yeah, definitely, I agree.
Yeah.
And sometimes, it may not just show you, a typical pattern of, topography, or like Jane said, there's no scissoring effect. It could just be a regular apical cylinder to start with. But as time goes by, because of the pathophysiology, sometimes patient with eye rubbing, it will generally make the progression faster and causing from apical cylinder to the skew astigmatism.
Mm-hmm. Do you have an ideal lens diameter to HVID ratio that you like to use?
Ratio between lens diameter and HBID. I think one slide I point out is approximately, I usually aim for 90 to 95% of the HBID for the lens diameter. But
Okay.
also depends on the overall K reading. If for someone having a steep K greater than 46 diopter, most of the time I will start with a smaller diameter, despite the fact that patient may qualify for a larger size, but because of the K reading, we'll start with a smaller diameter for them.
Mm-hmm. Matt was asking if your topographer measured sagittal depth, because he hadn't noticed that on his machine. I think you were showing us a Medmont, and which
That's
does
right.
have that capability. Is that
For Matmon, in my knowledge, I don't think it will show
no?
you sagittal height differential, but it will show you the mathematical calculation, right?
So
And
you have to do the math.
you have to do the math, manually, all
Mm-hmm.
right? Whereas, in a different equipment, like for example, the one I show you is the Pentacam AXL. It will
Mm-hmm.
actually help make the calculation for you. So just a matter of different equipment you're using.
So if you're not exactly sure, you can certainly talk to whoever sold you the machine or go onto their website. So you'd be looking at if they don't give you the actual sagittal height difference, is there a way you can measure the two different axes, just like you showed with your Medmont, and then mathematically do the calculation between steep and flat?
Yes, you can definitely do so manually, and sometimes in some complicated cases, I even have to divide the meridian by quadrant. So you have to do a lot more in-depth analysis in order to really appreciate what the cornea actually tells you. Sometimes the vertical and horizontal meridian doesn't tell you the full story, but what I show you tonight is just the basic guideline of what to do with the sagittal height differential.
Now here's another one. This is interesting. Do we add on the spherical equivalent of the difference between the delta K and the refraction cylinder to the target power to enhance or mask the vision to avoid undercorrection? So they're kind of adding a little bit of extra power to it. Do you recommend doing that?
Yeah, that's another interesting question. I think my experience tells me that it's it's generally better overcorrecting a patient than undercorrecting a patient, regardless of what you do and how you apply the formula. And but I would do it slightly differently. I would not, take the K delta and do the spherical equivalent. At least I haven't tried it before. I don't know if it worked well enough or be able to approximate the precision well enough. But the take home is that I generally was, if necessary, I would generally slightly overcorrect the patient than undercorrecting the patient. That will actually help maintain the overall goal of myopia management, because study have found that undercorrection would exacerbate the progression over time.
Yeah, it's interesting. Somebody else had asked about the limits, that the our government regulations put on us. So, like in one of your examples, I think you used somebody who was a 575, and of course, we can't produce a lens higher than a 5. Generally in the U.S., some companies are limited to 4. Other ones are, up to, there's different companies with different limits. But I always use the rule of vertex too, that I can always, for a 5.5 refraction, I really need a 5 at the corneal plane. Does that make sense to you, or would you go for
Yeah,
the
that's
full?
definitely doable. And I think Jane brought a good point that um, generally we don't fit Ortho-K greater than the basic parameter that I show you. Depends on, what your comfort levels are. For starter, we generally don't recommend clinician to go beyond -5 or having the astigmatism greater than 150. But for that case I show you, it's actually, we have done a lot of, background search and, analysis with a consultant. And this case is not easy, but we end up fitting the patient with the off-label application of Emerald product. So, but the take home is that, you can definitely consider doing off-label use for patient go beyond the parameters. But for starting, you don't want to go too aggressively.
So I think we've answered a few of these. Topographer you're using, and A-scan. So you had Pentacam, and your topographer was a Medmont.
Mm-hmm.
Those are what you,
That's correct.
okay. What software do you use for differential analysis? You got any?
The example I showed you was by the Pentacam AXL by Oculus, and that's the one would do some sort of automatic calculation for you. And but again, manual calculation is also pretty easy and straightforward as long as you know what to do with them.
Mhm. Wow, we got so many. People are asking a lot about how do you measure sagittal height, the the sagittal height. Do you have a way of measuring that? How do you measure
Um,
sagittal height?
Typically, I would start with having the specific cord length. Usually, I use the 8 mm in size. That
Mm-hmm.
will consider the typical where the toricity lies on the cornea. But sometimes when the patient are having narrow lid up positions, 8 mm may not be big enough. You have to go down by maybe 0.2 interval. But I will start with the 8 mm cord length, and then go from there. Because once you click the functionality on the calculator, they will actually show you what the sagittal height on each meridian, and that tells you the overall differential.
Here's a good one. Somebody asked if there are scribe marks for the axial rotation, or is just dependent on fitting.
So the question was, is there any marking for toric lenses? I think not that I'm aware of. At least for Emerald product, they don't have any marking for toric lenses, but they will come with different color scheme. Is that correct?
Well, the markings you don't really need, because it is going to automatically align itself along the steep and the flat meridians. So once you give them those two measurements, however you put that lens in, it's going to turn itself to the righted position. So it's not like a front surface toric soft lens where we're having to allow for that. This lens is a back surface asymmetry, so it's going to go to its natural position. You don't have to measure it or look for it. It's going to be there. I hope that made sense. Let's see. Oh, I think we're going to end on this one because I know it's late, but this is a good one. Do you think it's okay to prescribe a diluted proparacaine for the first week or so to use only at night before bed? What do you think, Dr. Chan?
That would be clinically unnecessary, in my opinion, just because I rarely put proparacaine or dilute proparacaine for most of the patient, simply because my philosophy is we don't want to have the patient adapt to the proparacaine too much to the point where when they don't have the drops, they will not be able to wear Ortho-K lenses. So upon the first day or even the first INR fitting, we'll walk through the patient what the realistic expectation would be, but we don't want to give them proparacaine too easily. But again, it varies from clinician to clinician, and if you're comfortable having diluted proparacaine, that will be up to your discretion. But again, having any type of diluted medication would be quite risky because you don't want to risk any contamination if you don't do it in the sterile facilities.
That's exactly a perfect answer. Now I'm going to let this one be the final. I said this before, but this was a good one. Daniel asked if a biaxial lens design is the toricity added to just the landing zone. And I know you had a diagram up there, but in the Euclid Toric, the power curve, the base curve, is spherical. The reverse curve is toric. Both of the alignment, the fitting curves are toric, and the peripheral curve is spherical. So I hope that answers your question, Daniel. If not, please, any of you, if you have questions for Euclid, please don't hesitate to call our top-notch consulting team. They have helped me so many times through the years. They'll give you limitations. It depends on how much cylinder, where it's located. They can walk you through it. If you've got any questions, I do recommend you give them a call. I want to also thank Dr. Chan for his expertise in this area and his great advice that he gave us. So, and I'm sure he will be glad to also be in contact with you. So please don't hesitate to contact us here at Euclid. We have up here our Vice President of Sales, David Bland, and our phone number. Please don't hesitate at any time to be in touch with us. I do want to end tonight by asking you to do something that sometimes I don't understand this, but they tell us that they want us to follow Euclid on LinkedIn or on the Euclid Facebook page. And I have learned that by doing that, they'll send me little pop-up announcements. We have webinars like this one scheduled through the next 3 or 4 months, and we've been doing a series of Facebook Live conversations where we get a couple of practitioners and we ask them questions, and it's moderated by Craig Norman. So again, it's independent, and they've been great learning and great fun. So we have another one of those coming up on Thursday at 1:30. You go to the Euclid Facebook page and you can like it, and then it'll pop it up for you. So I hope that, don't ask me social media questions, but I know those things have been very popular, and I hope you will join us for some of them. So again, I want to end the evening by saying thank you to Dr. Chan, thank you for our production crew, and thank you for all of you for attending this session. It will be posted on our Facebook Live if you want to go back and listen to it again. I know I do. Thank you all.
Thank
Good
you so
night.
much. Have a good night.